Hello and welcome to the Headache Doctor podcast, where on this podcast, it's our mission to educate and empower everyone with headaches and migraines so that you can break free from a life of fear of your next headache or migraine and dependence on medication. In today's podcast, we're going to talk about the basics. We're going to go back to the basics and understand the why behind headaches and migraines. So this is the theme that goes across all of these podcasts, and we're going to connect all the dots. This is something that I was looking back through the recent episodes over the last 2-3 months, and if you are just jumping into this, and oftentimes in the summers or after the school season dies down, we'll get new listeners. We're always getting new listeners that pop on this podcast, and there's almost 200 of them. And so what I want to do is reorient everyone to the why behind headaches and migraines, what we talk about here, why I personally am so passionate about this topic, and then what we do here at Novera Headache Center to actually help people get rid of this problem. If you're a longtime listener, if you're a regular listener, I do find that people that have listened to the podcast over and over still have sort of this sense of, well, is this true for me? And what exactly is happening? And so repeating the fundamentals and the why behind headaches and migraines is really important. And so if I'm saying things that you've already heard, it's hopefully going to reestablish it, just cement it in this is what I need to pursue in order to find relief. So a little snapshot into my story. So I'm a physical therapist. Sometimes people interact with us or they call, and they actually, I had a question yesterday from a client or a patient that I was interacting with, and they didn't realize I was a physical therapist. So I'm a physical therapist. Nothing, it's actually, it's the single best education that I would argue that someone can have in order to understand and then address headaches and migraines as a neck issue, jaw issue, shoulder issue. You see, the problem is that there's movement within certain segments of the neck, jaw, shoulders, and how we function that aren't functioning. They're not moving the way they should. And so when we think about the type of provider that would be able to understand and treat that, well, that would be a physical therapist. So a physical therapist, it may pop into your head that this is someone who, physical therapist is rehabbing a total knee replacement, or maybe you had an injury and you're doing exercises or following a plan that involves movement and strengthening and stretching and that sort of thing. Well, that's true. That's not far off from what we do. Our specialty is in restoring function, just like any physical therapist would in any setting. We're restoring function, but specifically to the head, the jaw, neck, shoulders, okay? The thing that is true that this podcast and our practice being a specialty practice for headaches and migraines, the reason that we don't say we're neck specialists or we're jaw specialists or we're shoulder specialists is because these areas manifest themselves as pain in the head and the face. And so the connection between the upper part of the neck and you having stabbing pain behind your eye, pain, a strap-like pain in your forehead, pain that shooting, stabbing in your temple, whatever your presentation is, maybe it wraps up and around, that pain can be sourced back to the neck. And we actually want it to be. If we're not finding a source, then how do we know what to treat? And that's where people get lost in medication. And so my story is that graduated from physical therapy school, started working on the neck, jaw, shoulders, found that it helped people with headaches, ran into patients with migraine symptoms. At first I said, I don't know what this migraine thing is. This is something the neurologist needs to take care of, because that's kind of how we were trained in PT school. Refer out if it's something that's outside your scope. Well, come to find out, these people said, I've seen all the neurologists, I've taken all the meds, and it feels like I have a neck problem. And so we'd work on their neck and their migraines would reduce or go away. It just kept happening. With that experience, I dug into the literature and said, what are these neurologists using to guide their practice? Found that it was all based on it was subjective information they were using. So you tell me what your symptoms are. We'll do scans or images to make sure there's nothing else that's causing it, and then we'll treat your symptoms, all right? It's treating symptoms. It's not treating any underlying cause, all right? So most head and facial pain, whether that's migraine, whether that's occipital neuralgia, trigeminal neuralgia, whether all the different various types of migraine, all different types of head and facial pain can really fall into that sort of model, what I just described. If you describing what you feel, the provider on the other side, whether that's primary care neurology, sort of reflecting back, okay, here's the type of medication that seems to work well for those symptoms, but no conversation about the source or why is this happening. And what that did was that really frustrated me, because I'm thinking, okay, there's so many people that have this problem and it's so debilitating. And here's a perfectly reasonable solution, because on the other end of that journey, it was understanding why the treatment to the neck was actually working. And it's because when we look at the anatomy, when we look at the physiology and how our nerves and our brain is connected to joints and how it receives pain signals and what happens when we have inflammation, it's really fascinating, because we have what's called referred pain. And referred pain is well known. It's well documented. If you, probably the most common example is like if you have a heart attack and your shoulder hurts, or let's say you hurt your knee and you press on a bruise or something like that, and the pain shoots down your leg, something like that. So the pain is referring, or it's spreading. The brain is picking up the signal as coming from somewhere else other than the exact location of the tissue trauma. So referred pain tells us that pain is subjective. It's not to be taken as like, okay, here's where it hurts, so here's exactly where the problem is. And so when we have pain in our head and we think about the head, sure, we want to evaluate what is happening in the head to make sure that there's no underlying problem. Now, most people, I would say, in a world where we're able to see someone when they have a headache in the early, maybe you've had a few headaches and you're just like, man, I need to try to figure this out. Within a month or so of having a headache, we can screen your neck, jaw, shoulders, and really make sense of it. And so you don't have to go through the process of getting an MRI, CT scan, X-ray, and look for those other things, because we have an answer. The problem is that our healthcare system's flipped. And so flipped in the sense that you have a head, you have pain in your head, and then you go to your primary care, your neurologist, and they do the scans to make sure there's nothing else like objectively causing headaches. And then they would chalk it up to this is a spontaneous neurological event. Okay. Now, they might not actually say that. Very few patients I've interacted with have actually heard a physician explain this as just a spontaneous neurological event. I would venture a guess that most would just sort of leave it and not provide really any explanation and just prescribe the medication. That may be due to a lack of time in the appointment. That may be due to just a lack of confidence in understanding what is actually happening. And so there's a gap there, and the patient is experiencing this. No one's telling me what is actually causing these symptoms, and I'm having to take these medications which have side effects, and patients know it's just sort of like a Band-Aid, and then wanting to find like what is actually at the bottom of this. And so a lot of people are just on this journey, which is a very fatiguing journey, of trying to find what's at the source. So go back to pain. Now, pain can be referred, and we know that anywhere from the base of the skull, okay, base of your head, the backside of the head, if you're watching on YouTube, I'm pressing in sort of this fleshy part just under the base of the skull and the back of the neck. Now, that area is where C1, C2, and if you go a little lower, C3 sit. Now, we know that anywhere from the base of the skull to C3, any pain signal from that area, so any of the muscle tissue, any of those joints, any of the ligaments, any of the nerves in that area can refer pain or send pain into the head, okay? Now, what that means is the occipital nerve can be irritated. That's the nerve that runs up around the back of the head. Okay, there's a couple of greater and lesser occipital nerves. So that brings a pull sensation from the back of the head. That's sort of that wrapping up and around sensation. And then you've also got the trigeminal nerve that can be part of this sensitized area. The trigeminal nerve picks up sensation from the forehead, the eye, the cheek. So 3 different branches, they pick up sensation from the head and the face, okay? So we've got occipital nerve, trigeminal nerve that can all become sensitive because the upper part of the neck isn't happy, all right? Now, the reason that happens is because this pain signal, let's say that something is not functioning well in the upper part of the neck, and then there's pain that is triggered, that pain signal travels through the brainstem. And this is where all of these nerve pathways sort of meet up before it actually goes into the brain, or what's called the cortex. And so the brainstem has all these little pockets of bundles of nerves that have all met up that carry similar types of signals from similar parts of the body, okay? And so when it comes to the upper part of the neck and the occipital nerve and the trigeminal nerve, they all meet in what's been called the trigeminal cervical nucleus, okay? So we call it a nucleus. And so all of that meets up in the brainstem, and then the brainstem sends that signal up into the brain. Now, what's interesting is we don't really acknowledge or realize what's happening in the brainstem. We're not aware of it. It's all automatic stuff that's happening. We realize what's happening when it hits our cortex. Okay, so all of that process is automatic. Like we don't feel pain at the site. We don't feel pain in the brainstem. We feel pain when it hits our cortex, when it hits our brain, and our brain gets this signal, and then it has to sort of decipher what is actually happening, okay? So think of your car when you're driving down the road and something seems to malfunction, and it's not something that you're really aware of, but the car's computer understands what's happening, and then it sends you that awful like check engine light, okay? So there's a problem somewhere in the engine, and it's traveling through the computer, and then it hits your dashboard and shows up as an indicator of a check engine light. Now, all you know is that there's a check engine light on, and so you can say, okay, there's something wrong in the engine. You don't know exactly what it is, and you don't know exactly where it is. Now, the problem is actually in the engine. The problem isn't that your check engine light's on, and so it'd be a silly thing to just tape over like the check engine light with black tape and hide it. What we need to do is understand what is actually happening. And so we get this pain signal in our head. And of course, if the head itself was hurt, let's say you hit your head, or in rare scenarios, I actually haven't run into this yet, there would be something like a brain bleed or a tumor, and those are different categories. So by and large, like people with headaches and migraines and how prevalent it is, like it is not one of those things. But of course, that's where our healthcare system is actually really good at catching that stuff. The thing that they're not so good at is catching the neck problems and the jaw issues and the shoulder problems. That's why this podcast is here. Okay, so assuming you're in that category, the brain gets that signal, and when it gets a signal and it says, okay, something is wrong in the head, all right? Like the head hurts. We have to think backwards from that. And it's well documented that the upper part of the neck, even the shoulders, the jaw, can all send pain into the head. And in these different patterns, like it can send pain as a migraine, in that like one-sided pounding, throbbing sensation. It can even cause sensitivities to lights and sounds. It can cause nausea. It's caused GI upset or GI pain, ringing in the ears. All sorts of different things can happen when this tension builds. And so we have head pain, and you sit and you talk to your provider and you say, this is how my head hurts. Now, instead of just screening for using still images like x-rays, MRIs, maybe blood work, things like that, what we need to do is look at movement, because the things that can cause the head pain are the things that move. So that would be the neck, the jaw, the shoulders, okay? So if we look at the neck, we'll start there. When you rotate and look up and down and side to side, there are the upper 2 joints in the neck. So it's the head sitting on the first bone, which is called the atlas, and then the atlas sitting on the axis. Now, it's called the atlas because it holds up the head, okay? And then the axis is there. It has a thumb-like structure, and the atlas sits on top of the axis. The reason it's called the atlas is because it rotates on that thumb-like structure, allowing us about 45 degrees of rotation to either side, right? most people we work with, even though that atlas and axis joint isn't allowing the 45 degrees, and most of the time it's not really allowing any rotation, they can still turn their head all the way, about 80 to 90 degrees. So what that means is the neck is able to compensate with the mid and lower segments of the neck, picking up the slack, maybe into the upper back, maybe the shoulders have to kick in a bit more. And so there's added stress to the mid portion of the neck, but the main problem is the upper part of the neck, okay? Now, the reason like an X-ray and MRI wouldn't show this is because it's a still image. So we're talking about how things move. And this is where oftentimes people ask me, like, well, how is this different than a chiropractor? Because there are lots of chiropractors that are very skilled and comfortable treating the neck. The model, their framework generally that's being used is an alignment or subluxation model. Okay, so they'll take an image like an X-ray, and they'll look and use like the degrees of angles of the spine and say, okay, this is where the alignment's off, and then make adjustments. Okay, so again, it's still images, and that's where the physical therapist, like what we do here and trained in how to restore function, is important, because we need to understand how it should move, why it's not moving, and then how to get it there again. Okay, so the why behind all this, of why is this not moving? Why does my neck not rotate? In addition to the rotation, there's also nodding that happens between the head and the first bone. Oftentimes our heads are kind of forward and cocked back, and we just sort of lose the available motion through what's called the OA joint, the head, the occiput sitting on the atlas, okay? So that OA joint doesn't nod, we don't rotate. There's a lot of tension built up back here. If you press on that spot, you'll probably feel, oh yeah, that's kind of sensitive, or that's where my headaches start. We hear that all the time, okay? So that's that high real estate area that can send pain into the head through that trigeminal cervical nucleus, and gets irritated because it's not moving. So picture this joint that's not moving. I use a telephone analogy. Everyone knows you hold the phone up to your ear and you're talking on the phone, and after about 15, 20 minutes, you realize, oh, I got to switch the phone over and I have to extend my elbow because it's starting to hurt. Why does it hurt? Because you're not using the motion that's available to it, and that's a normal response. The body wants to move. If we don't move over time, over months or years, it'll actually adaptively shorten. It'll adapt to the loss of movement or the lack of movement. And over time, if you held your elbow like this, the elbow would actually forget how to extend, okay? But in the short term, there's irritation. Now, if you hold your elbow there, that irritation would continue and it would ramp up, okay? You'd become more and more sensitive to it. You become more aware of it. You'd probably get pain that's referring up and down. It would change the way that your shoulder functions because you'd have to compensate. Your wrist would probably take on some stress. And so that's what we're dealing with in the neck, okay? So and it can come about from trauma. So it's not just like you were stuck in one position. And when I say stuck in one position, think of like, desk jobs, sedentary lifestyles. Like we sit a lot. And so just the sitting with a 10 to 12 pound head, the weight of a bowling ball, can add enough stress to the upper part of the neck, which is very mobile, to cause irritation. Trauma can definitely do this as well. The most mobile part of your neck is that upper part. And so if you get in a car accident or you fall off a horse or whatever it may be, a football injury, and you have whiplash, your head, again, a 10 to 12 pound weight, like a bowling ball, is thrown one direction, and your neck can't necessarily react quick enough to protect itself. And so there's sort of this shearing effect. Well, within a week or so, the neck pain itself will probably die down, but the change in how it functions will still be there. Maybe there's scar tissue that's developed, maybe that compensation's there. And then over time, you might increase the level of tension through that area because it's not moving quite like it should. And then you develop headaches or migraines, okay? Now, what we do about this problem, before I get there, the neck will also impact shoulder function. It'll impact the jaw and vice versa. And so we won't go into it in too much detail, but the shoulders and how they function. So if you've had a shoulder injury, the shoulder will anchor on the neck. Now, the shoulder should be independent of the neck to some extent. Like it shouldn't be relying on the neck to hold it up. Like if you lift a heavy weight or just carry a purse on your shoulder, the shoulder should be able to do that no problem. But when the shoulder is dysfunctional, we have a few muscle groups that insert into that area of the neck, the upper part of the neck, and can kind of act as a tethered rope that's pulling. And as it pulls, it again adds to the irritation. And so we want the shoulders to be stable. I also mentioned if the upper part of the neck isn't moving, then the mid portion of the neck and the shoulders probably have to kick in to sort of get the movement that should be there. And then, of course, if the upper part of your neck is stiff, it could change like the resting posture of your head. And so that the angle that your head sits and gravity pulling down on your jaw will add stress over time, usually more to one side than the other of the jaw. And then the tension is also translated. Now, there's other reasons that you might be in this situation. So this isn't a full comprehensive list of why. I've had other types of providers, like we've talked about tongue tie and airway. That's probably one of the biggest ones we see that causes a lot of tension. And so our model is to, here at Novera, we look at the things that don't move and we want them to move. So we're addressing the actual source of pain itself. But we also want to look at like developmentally, what might be barriers that someone might have that would prevent them from finding the relief they're looking for, or their body from moving like it should. That could be hypermobility, genetics, and from your anatomy, and you're just sort of kind of your anatomy. Maybe you have a really long neck or a really weak neck, or you're hypermobile. Like those things can set someone up for being at higher risk of developing this type of injury. But also things like airway or tongue tie, the things that would cause your jaw and your neck to have to compensate increasing tension. And then lastly, we'd want to know what are the things that impact your threshold. And these are the things like the hormones, the diets, the allergies to certain foods, the seasonal allergies, the things that impact your body's ability to handle this pain and tolerate the pain. And so when we understand the why behind, well, like why would your head hurt, and we think about the mechanics of it, and then we look at it from a perspective of, okay, like what else could be impacting it? And then how does our body experience pain, and what is this threshold? And we put that all together, we start to make sense of all these questions that are out there. So when we think about triggers, we think about, okay, like what foods do I need to avoid? Is it my stress level? Is it because I didn't sleep well? Am I dehydrated? Is it the pressure change? Is it hormonal? All of those things start to make sense because those things alone, everyone will experience, okay? Everyone will experience them. Now, not everyone has a headache or a migraine. So what's the difference? The difference is we have this neck, jaw, shoulder issue that's actually causing irritation and pain because our body's having to try really hard and come up with compensation patterns, and there's added stress to the joints, to the ligaments, to the muscles, and they get irritated. So there's an actual pain signal being sent. But then on this other end, all these other things impact how we're able to cope with that and our threshold in tolerating that. And then we think about how our bodies developed and what it was like when we were a kid. Did we have a tongue tie? Did we have to try to swallow and compensate, and that increase? So all of these things come into play, and they start to make sense and they start to click. And it's been amazing because we have people that fly in from all around the world, all around the country, and then locally, of course, and all different types of headaches and migraines. And using this model, now, of course, like the rate that someone would progress, how quickly they progress, their specific pain, how their brain responds, if they have hypersensitivity that's developed, the type of symptoms, how their neck needs to be treated. Like there's all these different variables, but using this model has been effective for nearly every type of headache or migraine that we have seen. And so the things that I want you to walk away from this podcast with is understanding the why behind your pain, and then not having to dismiss like the fact that you've been avoiding triggers or like changing your diet helped, because all those things are definitely playing into your overall experience and they're valid. But using this mindset and this framework to then move forward with confidence of like, I don't have to just rely on meds and slap a Band-Aid on this. There is actually something that I can do, and there's an objective problem that can be treated. Now, if this sounds like you, what I want you to do is reach out to us here at noveraheadachecenter.com. You can call the front office. You can book an appointment online. Just reach out to us in some way, and we'd be happy to help you. We have in-person visits, of course, and then we also work with people through our virtual coaching program. And then I want you to continue listening to the podcast. Follow us on our Instagram, YouTube page, Facebook, TikTok, wherever you wherever you spend your time as far as social media. Find us there, and we'll have other helpful resources for you, like videos of stretches and things like that. But don't feel like you have to wander through our healthcare system any longer. I mean, reach out to us, and we want to help you solve this problem. Thank you guys so much for listening to this podcast. It's a blessing. It's an honor to do this week after week, and I love it. Stay tuned next week for more information as we continue on this journey of educating and empowering everyone with headaches and migraines so that you can break free from a life of fear of your next headache or migraine and dependence on medication.